Thank you very much indeed for the introduction, and just have to say that thanks to Honora O'Neill here in the audience, is the one responsible for the fact that we talk about data use being trustworthy rather than asking that people trust it. I think that's a very important point, and one I'll pick up on as I talk, because I think there is a risk often when we talk about public views and public attitudes that we say that the public must trust what we're doing, and rather I think we need to be thinking about the systems, the governance, the decision making that's in place, and how can we assure that we are making those worthy of our trust, rather than expecting people to do us a favour. So I'm going to take a slightly different perspective on value, and I think that some of these questions and issues have already come up, thinking about the idea of the value of data being something other than monetary and something other than financial. And I think that's because that value question has both positive and negative aspects. On the one hand, value can be about social, personal, psychological values, benefits, both for individuals and communities when it comes to their healthcare and their treatment. But it also involves slightly more abstract things. Could better increasing use of data enable increased and enhanced dignity? Could it empower individuals to take more control, responsibility over their own healthcare and their conditions? And Eric Topol talked about the gift of time in his recent review. Could better use and more efficient use of data that's contained within the NHS enable clinicians to have greater gift of time with their own with their patients, rather than constantly having to be doing paperwork and not necessarily focusing on the things that should matter to that really important doctor-patient relationship. But value also has negative connotations. There are risks, there are potential harms, not least in relation to things like privacy breaches, misuse of data, but also risks not necessarily through misuse, but just through poor design. Poorly designed tools, algorithms and so on that perhaps have used data that's not particularly representative of the populations it's hoping to serve or to be applied in. People being excluded from data, or on the other hand, inappropriately targeted. What about if there's inaccuracies in the data that lead to the development of guidance or guidelines or tools that create issues for safety and so on? So value, I think, has both positive and negative aspects. But the thing to draw out here is that really this notion of the value of data fundamentally lies in the uses to which it is put, to the purposes for the use of the data. It's inert in and of itself. It's not necessarily something that you can... I think there's big questions about whether it's worth putting a financial value on it, a monetary value, and saying this is what this is worth, because it fundamentally matters what you're doing with that data and what the purpose is for it. Interestingly, I think this is one of the many reasons why we shouldn't treat data like property or think of it in terms of ownership relations, but perhaps that's something we can delve into in the discussion. So thinking then about value in terms of the purpose for the data use, what are the purposes that patients and the public think matter? And that's something I'm going to be talking about more today. It's important to note that we have to get beyond thinking about just privacy here. Very often when we think about data, we think immediately of data protection laws, consent, privacy issues, and so on. But actually we need to go far beyond that, because the things that matter to people go beyond what matters to themselves as an individual and their own control or choice that they might have and the rights that they might have over data about them. It goes far beyond privacy. People care about a lot of other things beyond these questions of privacy and data protection. And we've recently run a series of citizens' juries in conjunction with the Office for Life Sciences and NHS England that have tried to explore these questions of value through the lens of what is it that constitutes a fair partnership between patients, the NHS and academia and industry and charities when it comes to the use of NHS data. And the reason I don't have slides is because unfortunately we are not able to publish this work yet. We are somewhat stuck in Purda, and I'm sure many of you will appreciate this is a rather challenging time for that. So we can't actually publish that yet, but I will give you some of the high-level insights that we've gleaned so far from these juries. Now, the purpose of doing citizens' juries, for those that don't know, these are events that last. Our ones lasted 2.5 days, and that's very short for citizens' juries. They can last up to 5 days. And the idea is that you have a really comprehensive, deliberative process by which you work with members of the public to explore quite a lot of depth the questions that you're addressing. And these are members of the public, quite a wide diversity of them, and they spend 2.5 days understanding, learning about questions around health data, asking questions, consulting experts. You have expert witnesses. You're trying to be as fair and impartial and balanced as possible, so you present both people who are very positive about the potential for data use, but also those who are critical of it and have concerns and scepticism. And we asked them, what do you think constitutes a fair partnership when it comes to the NHS allowing access to data by commercial organisations, by academic organisations, by charity organisations? What should the NHS and patients get back if they're allowing access to some of this data? Now, unsurprisingly, one of the top things there was there needs to be public benefit in this. There has to be that benefit back to the NHS and to patients. But that's not mutually exclusive with the idea of there being some commercial incentive and potential profit emerging from that. The key thing is that the public benefit has to be primary. And what do they mean by that? Well, first and foremost, better outcomes for patients. And interestingly on that, there is quite a lot of scepticism about some of the promises that have been made about the potential for data. We can say there's going to be all these benefits, it's going to be fantastic, and actually there's scepticism. People are saying, really? I don't really see how that's actually going to happen in practice. Or if it happens here, will that happen more broadly? Was that just going to be an isolated case? So I think that's helpful scepticism, particularly because AI in particular has been so heavily hyped, the promises, the revolution of AI in healthcare, and actually it's quite helpful to have a somewhat sceptical public really challenging us on whether those benefits really are going to accrue. And the other aspect is, in terms of guaranteeing benefits, the very nature of research is that it's uncertain. You have a research question, you want to do some research using data, you think you might get a certain outcome, but of course you've got to do the research to find that in the first place. So again, over-promising on what those benefits and outcomes can be does not do you any favours. And it's important to note that even if that data has been through a process of anonymisation, people still have a stake in it and care what happens to it. So it's not just about my own personal data, and if you take my name and address off it, you can do what you like with it. There's still a very strong underlying ethos there of solidarity, of reciprocity, of wanting to ensure that those benefits are coming back to patients and the NHS, even if it's not necessarily data about me as an individual. There's a strong rationale for helping the NHS run better, supporting its underlying ethos. And it's interesting to note Sarah's comments on the sort of the regional, national split potentially, because there is real concern about exacerbating health inequalities rather than reducing them. So where you do have organisations that may well have invested in their data infrastructure, are they going to be the ones that get all the benefits, leaving other areas less well off and potentially making health inequalities worse? That is certainly a real concern. There are also concerns in terms of other risks around exploitation for excessive profit, and I think that's certainly come to the fore in recent concerns around trade deals relating to NHS and whether patient data will be implicated in those. I think the one thing that's fair to say about that sort of risk of commercial exploitation is the only thing that's worse than selling data is giving it away for free. So whilst the idea of there being commercial benefits is not entirely anathema to individuals, that there is definitely a strong sense there has to be some exchange back, there has to be some benefit back to the NHS. So there's this very strong notion of public benefit, of social good, of public interest that's come through this jury process. And I think this is not a new problem in public policy. You're all very familiar with the idea, how on earth do you say what is a public benefit, what is in the public interest? But with respect to data use, I think there are two particular aspects that it's worth drawing out that I think create particular challenges. One is the illusion of objectivity that we may well get from the idea of using data, developing algorithms and so on. Data is not value-free. There are multiple assumptions, values, perspectives that will go into the collection of the data, to the questions that you ask about the data, to the algorithms, the processes that are developed off the back of it. But they may well be invisible because it looks as though you're creating some kind of objective process. A classic case of a kind of computer says no, we don't necessarily know why. And it's only when they result in harm that we suddenly go, hang on a minute, how was that decision reached? How was it arrived at? Are there biases inherent in the system? Particularly evidenced recently by the furore of the Apple Card that's appeared to be highly discriminatory against women. And actually it's worth noting that plenty of women and people of colour have highlighted the risks of these things before, but it was the Apple Card one that really seemed to strike public imagination. So we might think that we're being objective, but actually there's a lot of values and assumptions that are built into the use of data. Secondly, who gets a say in what counts as public benefit? And this is an area where I think Health Data Research UK, particularly thinking about the breadth and the depth of the engagement they're trying to do with patients and publics and citizens, is incredibly important. Because power tends to accrue to those who already have power. And we don't have a diversity of perspectives and views to bring forth to actually question and challenge those notions of public benefit. What benefits some people may well be at the disadvantage of others. And we don't have enough diversity of voices to actually to explore some of those notions of public benefit, and particularly when it comes to the uses of health data. And that's why we're particularly interested in engaging with a wide range of diversity of audiences when it comes to the use of health data. So I think the way that we frame the question makes a huge difference. And that it really matters. So this question about how we maximise, how we make use of the value of data, of health data, the way that we're framing that is really important. And I worry that we're in danger of a sort of tech solutionist or data evangelist approach if we start with the data and we say, we've got this data, how can we make the best of it, how can we maximise its value? There's a real risk that we don't think about the things that are necessarily actionable or could be incorporated into a clinical workflow clearly if we start with this idea that the data is king, the data is key. Instead, we need to reframe this. What are the problems and the challenges and the questions in our healthcare system that could be addressed or mitigated through the better use of data? You start with that challenge question, you're much more likely to surface some of the assumptions and the values that are going into your decision making and your thinking. How might better use of data help us solve those problems? And if we reframe it in those terms, then we've got the right notion of the value of data, which is a tool. It's a means to an end. It's not an end in itself. And I think once we're clearer about the ends that we're trying to achieve, we're in a much better position to work out where and how we might want to enable better use of the data in a way that's ambitious, realistic, but also fundamentally trustworthy. Thank you.